This is Waves, a podcast from APTA Michigan. I'm Andy Wicks. Primary care is a buzzing buzzword in physical therapy circles. But what does it really mean to you? My guest, Dr. Sarah Cruser, talks about how she envisions the role of primary care and health promotion in the physical therapy profession. I'll give you a hint. It does not involve creating another clinical specialty. Enjoy.
Hi, everyone. I am Sarah Cruser. I'm a physical therapist currently in Columbus, Indiana. My background started with kind of the outpatient ortho world, focusing on chronic pain. I've then moved practice areas a bunch of times, from that to older adults in their homes to back to the outpatient world with chronic pain and quality initiatives, and then relocated again and now switched areas, and I'm working in acute care at my local regional hospital. I live here in Columbus with my husband and have a 11-month-old daughter now that's keeping me pretty busy.
Yeah, I can only imagine. I remember those days.
Yeah, she's on the move.
Nice. And Sarah, you and I have been social media friends, if you want to call it that, for a long time.
Yeah.
But then we met face to face at the 2024 APTA Michigan Fall Conference, where you were one of the speakers. And I saw your name on. I was like, that name sounds very familiar. I'm going to go check it out. And I was like, I know why it's familiar. I know her from Twitter. So it was great to meet face to face. Your talk was really what kind of snagged me, because you were talking about health promotion. And so I was like, hey, let's talk about this on the podcast, because this is something that I feel personally is going to become a bigger part of PT practice in the future. I just wanted to kind of hear your take on it and just let you go hog wild. What do you want to talk about? Go for it.
Sure. Yeah. I mean, I think as someone who's practiced across the spectrum of physical therapy scope, right? I mean, I've gone from autonomous primary care practices to way downstream in the hospital where everyone is basically drowning. This is an area that has remained really salient across all of those areas for me, and I think is something that as healthcare providers we have a responsibility to do. So I think that the research is really clear that major health elements that are totally fundamental, things like exercising, eating a balanced diet, getting sleep, having social connections, managing your stress in a variety of ways, it's really, really clear that that impacts every area of healthcare and every practice pattern that physical therapists touch. And so we have a major responsibility to address it. And it doesn't really matter where you are in practice, it should be part of what we do. So that's where I'm coming from on it.
Yeah. And
I can keep riffing.
Yeah, no, I'll let you keep riffing in here in a second. But it's like when we say it like that, and you say things like, well, yeah, when you get good sleep and you eat good food and you have a good social support network, everything's better. Like, right. Of course, duh. But I don't think we make that next, maybe, I think a very small step, but to even say things like, your pain's going to be better, your function's going to be better, everything's going to be better. And I feel like that's where a lot of the disconnect is between what PTs do and what PTs can do.
I agree. I think there are a couple of barriers that people run into. One of them is sort of fearfulness around scope of practice. Mm-hmm. And two is it comes across as unconventional because we are so taught to live in this musculoskeletal or this cardiopulmonary or this integumentary practice pattern. But really, I often make the connection that, we know about health promotion and these kind of health elements as things that prevent problems down the line. Mm-hmm. But the fact of the matter is, like you're saying, if your sleep is better, your pain is going to be better. There are also things that are applicable way, way downstream in our practice areas too, so that when someone's coming to you after a knee replacement or with tendinopathy or whatever, these are components of their health that impact everything that they're going to be doing too. So it comes across as unconventional because someone shows up with a perception of maybe what to expect in an outpatient physical therapy clinic for tendinitis or a tendinopathy. They're like, okay, I'm going to get some exercises. So if you say to them, hey, let's dial in your sleep, or it sounds like you're doing everything right in terms of strengthening and loading your tendon and you're not improving, maybe it's your sleep, it might be unexpected for them.
Yeah.
But I would say, you know, as advanced providers, I mean, we all have advanced degrees. It's our responsibility to look at that, because otherwise we tend to hear that same narrative of, oh, well, you know, maybe they weren't doing their exercises, or it must be
The
something
non-compliant
the patient's doing, right? Yeah. And it's like, actually, maybe we just haven't zoomed out enough and looked at what all might be in their metaphorical cup.
Yeah. A big thing that I harp on, and it's a big like research interest of mine, is trauma-informed care. And I feel like that area and health promotion are like almost a Venn diagram that's one circle, because it's like,
Definitely.
if you don't zoom out with your patient care enough to recognize, wow, okay, you've been diligent with your home exercise program, why aren't you getting better like I would expect you to? And if you find out, well, oh, because they work 3 jobs and they're sleeping maybe 3 hours a night or whatever it is, like all of a sudden things make a whole lot more sense. Same thing. It's like, why has this seemingly kind of innocuous event become such a huge burden for your patient? It's like, well, because this is triggering some trauma from their past that's all of a sudden, you know, creating a whole nother, you know, big set of problems. If you don't address those things, you're missing so much with your patient care.
Right. Yeah. And I think too, I mean, that sort of brings me to the kind of framework that I always use for this type of topic, because, you know, when you're faced with someone in that situation who has macro or micro trauma on board and is in a really tough spot from a social determinants of health perspective, it can seem for both the person and the provider really overwhelming of, you know, well, I'm not going to be able to individually change this person's socioeconomic status, right? And that for a lot of people can be paralyzing in practice. But what I think is so cool about looking at multiple areas of health is it can be really empowering for people instead. So we can say, like, look, on the one hand, you have X, Y, and Z in your cup, right? And these are all of the things that are happening. And we may not be able to take all of those things out of your cup to sort of shift your balance and help you feel better. But here are all of these other things that might be either in your control to address, or maybe here's something we could take out here and add here to just kind of balance or sort of tip the scales for that person. And I think the fault that happens is people might look at each of these health elements, like your sleep, your nutrition, your stress, whatever, as weighing the same amount for every person if I were to kind of look at this scale, but they don't, right? Like for one person, sleep may be just this tiny little pebble that tips their scale a bit, but it's not really the major factor. And it may be that there's trauma on board that is weighing them down this way. And so for each person that has a different weight, and we as providers have to take the time to figure out what is doing what for each person we're working with, because then it gives you this ability to say, hey, I know, you know, here's what's going on for you. What do you think, what is in reach for you, or what can we do? And sometimes it's just having that, you know, provider relationship and having a person in your life that's advocating for you. Maybe that's enough to tip the scale a little bit for someone. I don't know. But yeah, there's a lot to address.
To have even just the recognition of, we can have a session where part of the session is we just talk, and you know, maybe you vent for a little while, and I say, yep, that sucks, and I'm really sorry that you're dealing with that, and let's see if there's anything that we can do to help that. That in itself can be such a shift. And it's, you know, it's like all we're doing is we're trying to humanize things. We're just people. We're all people. I heard a clip from Patton Oswalt that I cannot quote verbatim because it is definitely not for a family-friendly podcast, but essentially it's like, hey man, we're both clinging to each other in the storm here, trying to get through. Like, let's help each other out. It's not that hard. So I see a couple barriers when I talk to students about this, is like, how do you bill for that? But then you mentioned a little bit of that paralysis of, what can I do? I'm just one person, and this patient in front of me has so much going on. Like, what do you do? And so what do you say to those curmudgeons who don't want to help out?
Totally. I mean, from a billing standpoint, to me, so much falls under all of our CPT codes, right? Sometimes it's therapeutic activity. If it's things that you're doing in your life that are activities that bring you joy, maybe I'm having you look at a picture of your grandkid anytime you're feeling fatigued. that's a therapeutic activity to me, because it is something you're physically doing that's functional, that changes your status. So I bill TheraAct.
Yep.
Sometimes I bill neuromuscular re-education if we are doing maybe some down-regulating stress management techniques, diaphragmatic breathing, neuromuscular re-ed to me, unless it's maybe I'm telling you to do it at your office every hour for a minute or two. That might be TheraAct. There's also self-care home management that I think a lot of PTs forget about because it's such an OT-heavy billing code, but we can bill that one too.
Yep.
So that's another one. I mean, if we're talking about food and food choices and food prep and ideas, recipes, things like that, sometimes that'll be self-care home management. I think that's legitimate. I used to work in quality assurance.
Oh,
I feel
yeah.
like I have a little insight on that one. And I you be creative. It's no different than the way we might bill a squat as either TheraX, TheraAct, or NeuroReed.
Yep.
Just depends on the purpose.
Yeah.
So I think billing's easy.
We just gotta get creative a little bit. And I think that, speaking on nutrition real quickly, because I don't think a lot of PTs, well, they may realize it's within our scope of practice, but they're certainly not comfortable with it. Like,
Yeah, totally.
But I think it's certainly not something that we should dismiss. And I think we're not registered. Most of us, I'm guessing, are not registered dietitians, but we probably know enough to say, hey, we can find the free resources on, probably USDA or FDA.gov or whatever. It'd be like, okay, half of your plate should be fruits and vegetables.
Exactly.
Half of it should be, or quarter of it should be protein, quarter of it should be grains or whatever. Like, it's not that hard to come up with some options, but I feel like it's just, I don't know. We probably get so focused on productivity and all these other things that it falls off the radar so quickly.
It does. I think you're right that a lot of people get stuck in a scope. I mean, the APTA has been very clear that addressing nutrition is part of our scope of practice. I would argue the evidence is overwhelming for that as well, right? If just because we are physical therapists doesn't mean that the only research on OA that we read should be about exercise and OA. It's pretty clear that your fiber intake and your sleep also impact your OA outcomes. So we should also be looking at that research and applying those interventions appropriately if we're going to address OA.
Yeah.
I mean, I think that's just the basics.
Yeah.
The other thing is, as movement experts, and if we have growth mindsets and abundance mindsets, we should be eager to have registered dietitians share information with their clients, things like, hey, the ACSM recommends 150 minutes of moderate exercise per week, right? That is encyclopedia level information, right? Where you don't even have to cite it.
Yeah.
Right? At least, I don't know, back in my day when I was writing essays in high school, right? An encyclopedia, you don't have to cite. It's fundamental information. So we should be pumped if they're sharing that. And so for us, the type of information we are sharing regarding nutrition is probably similar level, right? We're not going to get into how many grams of carbohydrates you need to eat as a diabetic to manage your blood sugar. That's probably going to get referred out. But to talk about getting fiber, eating foods that bring you joy, eating a lot of fruits and vegetables, eating the rainbow, things like that, it's fundamental and it's available on public resources.
Yeah.
So it's totally in our scope to talk about.
I think another way to approach it for some clinicians who don't feel comfortable with that knowledge, because there's some of us who just don't feel like we have the knowledge, but you know what? We can find resources and we can point our patients to resources. And I think that's another thing that PTs, I've learned in my time as a physical therapist, especially when working with OTs. OTs are the best at it, I think, but to find solutions to problems. And it's like, okay, here is a problem. The problem is you don't have access. You live in a food desert, or the new term I've learned, food apartheid, which I thought was actually quite interesting. But and you don't have readily available access to healthy, low cost food in where you live. Okay, so let's troubleshoot then. Let's figure out how we can adapt and improvise and overcome here to help you get the nutrition you need so that your body can heal, so that you can feel better, so you can go back to your job, or whatever it is. We can draw the line. We can thread that down as far as we need to. But if we don't keep going back until we can find the source of the problem, and we try to address it farther downstream, then we're just not doing a very good job. We're not doing a complete job.
100%. And I think it goes back a little bit to our evaluation skills, right? Because I think that when we talk about these health promotion topics and how to implement them into clinical practice, it can be overwhelming again because people go, well, how am I going to address all of that in a session? And my answer is that, well, don't address something until you know it's an issue, right? I don't want to sit there and blast someone with information about nutrition if it's not a factor for them, right? That's like telling someone to get aerobic exercise and they're like, Sarah, I just ran a marathon yesterday, right? I mean, it's insane, right? So we have to come up with ways that we can evaluate and assess if health, these kind of elements of health, you could call them, are problems in the first place, right? Because they might not be. And then, okay, cool. I don't need to talk to you about your sleep.
Yeah.
Right? And then you're honing in on what you actually need to address. Just like if you have someone with that knee issue and they're already doing everything from a physical loading standpoint, maybe they don't need loading from me. Maybe they just need to talk about fiber or whatever.
Yeah. If your patient's range of motion is within
it.
normal limits, don't work on their range of motion.
Yes, right. So you have to assess, right? I mean, otherwise it is overwhelming because then you're trying to tackle all these things that aren't issues. And we wouldn't do that. Well, we might. I mean, that's kind of one of those transitions from novice to expert clinician anyway, right? Is that you see in a typical kind of outpatient ortho exam, and the more experienced clinician is going to be honing in on the objective measures they need to do based on the subjective, right?
Yeah.
And then based on the objective, they might do like X, Y, or Z special tests, but they're not going to do every shoulder special test. They're just going to do the ones they think are indicated. And I think it's the same thing with food, sleep, stress.
The expert clinician will have already made a dozen decisions about the patient before they've ever said a word, just because they're watching them walk in and be like, all right, these three things are probably not an issue. I'm going to work on these other things. Whereas the new clinician is like, everything is an issue and I need to address everything. Got to test it all.
Yeah.
I'm teaching a class right now for our third years. That's kind of their capstone clinical decision making class. It's my favorite class to teach because their students are at a point where they only have one clinical rotation left. So they've been through a lot. They know enough to be dangerous. And we have these conversations about like, how did you come to a decision versus watching your clinical instructor come to a decision, and what were the differences? And they're like, I have no idea how they came to the decision so fast. I'm like, well, because they've been doing this for 10 years. You know?
Yeah.
All right.
Yeah.
Okay.
It's no different with this stuff.
Yeah. Okay. If you, Sarah, could design and shape physical therapy to your liking and your image in the next 10 years, let's say, what would it look like? What would be different? I know this is an incredibly broad question, so you can take this in any direction you want. But what would change with how physical therapists practice? And you can even go back to how they would be educated, or what would be the expected outcomes. Would we have, as an example, a new clinical specialist of like, I don't know, health and wellness promotion clinical specialist? Probably not, but what would you do?
That's such a great question. I definitely don't see it as a specialty. That much I'm sure of.
Okay.
I see it as this needs to be fundamental in every practice. I think and I don't know if this relates specifically to health promotion. I think it does kind of in a roundabout way. But if I could change the field of physical therapy in the next 10 years, it would be that we truly work as kind of consulting and diagnostic clinicians. I think that is where we are currently limited by our entry-level education, at least what I experienced and the people I've spoken to so far. It may be shifting, and I get a sense that this is shifting in the DPT programs right now, and you probably can speak to that much more than I can, but I see it as, and I guess this is similar to like Rebecca Griffith, the ED-DPT, talks a lot about top of scope.
Yeah.
That's where I really see it going, is that there may be specialists, but that our generalists really are able to work as consultants who can zoom out and direct care, be it through referrals, be it through their own treatment, a PTA, a plan of care, depending on your practice setting, but to really feel much more comfortable with that primary care approach. Because even if you're a specialist, you may not be primary care in the sense that we use it for physicians, where it's like a practice area, but you still may be a primary provider who is there as a consultant, right?
Yeah.
If we look at the hospital, we consult with cardiology, and then there's this hospitalist that's managing it. So to me, I'd like to see more folks coming straight into the profession with that mindset of we are diagnostic. I mean, every state has their different definition of diagnosis, but I'm consulting a diagnostician.
I'm trying to think in my own experience. I worked in a clinic I worked for an organization for a long time we weren't inpatient rehab. We weren't subacute. We were kind of this post-acute transitional care, but we also had long-term residents and some outpatients. So we were in a weird little niche of care. However, we would work with some residents who lived in our system, like had lived there for 25, 30 years. So while we had, a physician who was kind of our in-house primary care physician, for a lot of these people, the OT or the PT or the speech therapist might be that primary contact, in that I'm not managing their care, but I might be the first person to see and recognize like, something has changed in the last 6 months we need to address. And so that then started the referral process to help this person get, whatever care was required. And I realized, or I kind of realized later on, like how unique and rare that actually is. At first I was like, oh, this is just great. I'm autonomous, and I can make the referrals that I think are necessary here. And we had a great little closely knit community, but that's not the case for a lot of people. And I think I agree that I wish that was more common. It's funny you mentioned Rebecca Griffith, also an alumnus of this podcast, but because she was just telling a story a couple months ago about how when she was working in the emergency department, she was asked to see a patient to perform the Epley maneuver. I think it was, or something like, some peripheral vertigo thing.
I remember that.
And so she was like, well, are you asking me to do a thing, or are you asking me to actually evaluate and assess this patient? Which she did, and found out like, Epley's this isn't BPPV, so I'm not going to do this. Like, the physician probably will assume good intent. Maybe they were stressed, overworked. We're like, it's BPPV. Hey, Rebecca, go do the thing. So I'm moving on. Where really it was, something's going on with this patient. I'm not really sure. Could you look at them in a consultant manner like you were describing, and to say, I need your opinion on this, rather is I need you to do this thing. And that's a huge difference.
We're not an intervention.
Yeah, we're not technicians.
What I love about it, though, is when we take that mindset, right, and we combine it with the idea of health promotion, of looking at all of these other factors that may be contributing to someone's health, we then have immense power to stop escalation of care.
Yes.
Right? So if I'm looking at someone in front of me who is dealing with all of these symptoms, but there aren't any kind of red flags on board or reasons to escalate, because I can tell we have all of these other factors going on that don't need medicalization.
Yeah.
Right? Your lack of sleep didn't need medicalization. It's not like this diagnosable sleep apnea. Then I have immense power to address those, or at least communicate to their primary care doctor, right? I was in a setting in which I had the privilege of working in this type of setting, where I could then talk to the primary care doctor and say, hey, no, I really don't think we need to stress about this from your perspective right now. We need to address X, Y, and Z. Like, no, I don't think we need that MRI or that blood test, because we're good. And that lets us then change healthcare, because we can say, hey, most things, if we start with eating well, sleeping well, yada, yada, things change. And we have to give it time to do that too.
Yeah.
Right? We don't want to pigeonhole people and all of a sudden say, everything is because of X, Y, or Z. Because then you do miss the big diagnoses, right? And I'm in the hospital right now, so I see the people who have shown up with a spinal tumor.
Yeah.
But by and large, most things we're dealing with feel better when generally you're doing these things for your health as best the world lets you.
Yeah. The idiom that's tossed around our first years hear it, and I've always assumed it was one of my colleagues that came up with this, but probably not actually. But when you hear hoofbeats, don't think zebras. The whole rare birds exist, but there's another book that we just read where there's a quote from it that said, "Common things occur commonly,"
For sure.
And guess what? Most of America is sleep deprived. So, but you can at least start with that question. Hey, how's your sleep? Doing okay?
Exactly.
All right, you getting 8 hours of sleep a night? Okay, then that's probably not the issue. Let's move on to something else.
Yeah, totally. Sometimes the assessment and the evaluation is simple to start.
Yeah.
Right? We have the benefit, as poorly as we are reimbursed and paid, we still have the privilege of time. Right? We get so much more time with people than any other provider. So you maybe you're warming up on the new step. And then you can be like, hey, how'd you sleep last night? Right? It doesn't all have to be this upfront run through, tick, tick, tick all your boxes and your questions.
Yes.
We collect information as we go anyway. And so starting to throw it in can be really, really useful.
Yeah. I'll even just use as my own example. So I had pretty major knee surgery about almost 5 weeks tomorrow now, as of this recording. First couple of weeks were awful. Just my pain control was not great. My sleep was miserable, like 3 hours a night, because I just couldn't get comfortable, kind of a thing. And I'm definitely the person who tells my students all the time, if you can do one thing for yourself, it's get good sleep. And my PT, they got me in there, started me on the new step, and my PT came over and asked me, hey, how you doing? And I don't even know if she got the words out of her mouth because she saw my face and she's like, you know what, let's go to a private treatment room here. You look like you're not having, and I was like, yeah, I was on the verge of a breakdown essentially. And she gave me that space to have a little bit of a breakdown and help me work through everything sucks because you're not sleeping right now kind of a thing. But, I was seeing my surgeon very soon. We worked out some questions. It was exactly what I needed. And just, it was like, I was laughing to myself afterwards because I was like, I both wanted my students to be able to see this interaction because my PT did such a wonderful job of not only, truly doing her job clinically, but also just being a kind human being. But at the same time, I'm like, oh, thank God my students didn't see me like this because it was, it was not at my best. Yeah. But it was like, it's a simple skill of recognizing the needs of your patients, but it's also in the realm of health promotion because if you're recognizing, wow, you are sleeping like garbage right now, and no wonder everything hurts, everything sucks. You can't do your HEP because you can barely function to get through your day. All this stuff.
Yeah, today's not the day to crank on that knee flexion.
Yeah, exactly.
Right? It's like permission. I think, and this is what's so hard for new clinicians, and some seasoned clinicians too, it's like permission to be human and permission to be creative a little bit, or permission to break out of the box. You have that list of things you're supposed to get for insurance purposes, but
I had an OT that I used to work with who used the term the therapeutic use of self. And I loved that term.
Beautiful.
Because it's just like knowing how your own presence can impact a patient-client interaction for good or bad. Because if you come in there a hot mess, well, guess what? Your patient's going to pick up on that real fast. But I think it was a nice clinical way of saying what you just said, of that permission to be a human being, and just not every minute of every session needs to be in an intervention. Your interventions might be, we are going to sit and we're going to take some deep breaths and we're going to get out whatever needs to be gotten out, and then we're going to move on. Yeah.
Totally.
Yeah.
Totally. Yeah. Yeah. That's such a hard soft skill, though. You have to be yourself and have your own style of treatment, but you also need to be the person your patient needs you to be in front of them at that very moment. Sometimes that is an extremely professional doctor-like person. Sometimes that's cursing with your patient, just being like, man, that really blows. Right? Sometimes it's giving them a hug. It just kind of depends on the person, and it's permission to play a little, and you're not acting, but you are changing your interactions.
The fun thing about
I think it's really
where I worked, because it was a TBI rehab clinic, there's a lot of swearing. It was fun.
Sure, totally.
I had a little permission, like, oh, your frontal lobe's gone too? Sweet. Let's just drop some F-bombs. It'll make us feel, there's research to show it'll make us feel better.
Definitely.
Yeah.
Definitely. Yeah.
So okay,
important.
This idea just popped in my head. Not a clinical specialist for health and wellness promotion, because I agree that's not the way to go. But what about a residency?
I
What
know
about-
people who are doing one.
Really? There is a residency?
Well, I think the folks at Proactivity in New Jersey
Tell me more.
have a residency. Yeah, so Mike Eisenhart,
Oh.
do you know Mike Eisenhart?
I know, again, Twitter.
Okay.
Yeah.
Okay. Yeah, for sure. So Proactivity in New Jersey is an employer. Most of their base is employer-based work,
Okay.
but not just PT. It's like a whole health promotion
Oh, okay.
thing. I probably can't give more details than
Sorry.
that, but they have a wonderful practice out there that's like a direct-to-employer practice. And they, on occasion, offer a residency position with them. It's not like a formalized ABPTS deal, but it's an
Interesting.
opportunity at times. So they have offered that in the past.
Nice. I often wondered if there'd be like a primary care residency, if that would be a thing.
Yeah, I feel like that'll be happening
That,
in the next.
that's probably a
few
lower
years.
lower hurdle. Yeah.
Yeah, I do feel like there's a lot of action isn't the federal
Yeah.
section with primary care PT.
They practically are already primary care providers there.
I know. There's a list of courses that are sort of through there, and Katie O'Bright, I think I'm remembering
Yep.
her name right, has a lot of courses on primary care PT, and I imagine that a lot of these health promotion topics are in there as well, or they should be. I'm the daughter of two family physicians who
Oh, nice. Okay.
went to med school kind of during the era when family doctors practiced the way they all wanted to,
Yeah.
I think, when they were getting into medicine. And now I have a lot of friends who are in primary care medicine now and, wanted to get into it for the reasons that I'm talking about now in terms of health promotion and kind of helping people before things get really tough and aren't really able to practice that way.
That's got to be really frustrating. Primary care physicians, to me, the good ones, you're like, man, you are one in a million. Because
One in a million.
How do
and
you
it's
have the
systems.
time? How do you keep yourself organized? Yeah. Ugh.
Yeah, the system is stacked against them for sure.
100%.
But we have, like, our scope of practice screams health promotion.
Yeah.
I mean, this is what we do.
Yeah.
Right? Is like we work on function and feeling good and moving through our days and our activities.
Yeah. Wow. If we
Right?
could,
I mean,
if we could put the resources into prevention instead of in terms of proactive medicine versus reactive medicine in healthcare, like our primary care physicians would get paid $1,000 an hour, and we'd have 1 million of them, and it would, like, imagine in my hypothetical situation here, how things would change downstream, because we would be catching so much early and preventing so much early that downstream care would be, now you're not waiting 3 months to see a specialist,
right. And so much is preventable. I
Yeah.
think that, but the huge narrative across the country, not just in healthcare, but for lay people, from advertisements, drug commercials, conversations with physicians, the type of visits and interactions they have with physicians, not because of the physician's fault, but because of the system, nothing is geared to prevention right now.
No.
Nobody thinks that if you get a prediabetes diagnosis that there's anything to do about it.
You don't see
Right?
any
I mean,
snappy
it's-
commercials for health promotion and wellness like you do for like an Ozempic commercial.
Right. Yeah, exactly. And so it's like nobody thinks about that. And like it actually does take a lot of work.
Yeah. Oh,
right?
yeah.
And it takes time.
Yeah.
Kind of like talking to someone about their tendinopathy. You aren't expecting them to actually get all the way better in 6 weeks when the ortho wants to see them back.
Yeah.
It's the same with these health topics, right? It's going to take a while for me to feel the effects of eating a really high fiber diet. But then when I do feel it and I feel the opposite, it's really important. I mean, that's one of the things that Mike Eisenhart always says. Like, people I work with always say, I had no idea how bad I felt until I felt good.
Yeah. That's true. That's true. It's not like it's like, hitting your head against a wall because it feels so good when you stop. But it's like you don't necessarily feel sick or injured. You're just, like, this just becomes your new normal. But then, man, once you change that, you're like, holy cow, how did I get through my day?
The other thing that happens, I think, when you take a health promotion perspective on typical PT diagnoses is it also can minimize some of the fear and catastrophizing that happens, right? Like, I had really, really bad de Quervain's tendinosynovitis.
Ooh.
Not long after having my kiddo, which is very common
Oh
for
yeah.
new moms.
My wife had that. Oh, it's awful.
Yeah, it was so painful. I've never really dealt with such a tendinopathy before, right? But I also knew that the things that were changed for me, my sleep, obviously, right? Newborn baby. I had, a change in my diet because I didn't all of a sudden have the time and leisure to make whatever I wanted to make. I obviously had stress, right? I had financial stress because I, just had a hospital bill.
Yeah.
I had personal stress, right? There's a lot going on. And so it gave
Because as
me
everyone knows,
permission.
pregnancy and childbirth is medicalization.
Yes, definitely.
Different topic, sorry.
That's a whole nother podcast. We can go through my hospital bill. But, it gave me permission to be like, I don't really need to do anything about this right now. I'm not going to worry about it.
Yeah.
I don't need to work on loading. I'm not going to do any eccentrics for my thumb. I'm literally just going to say, hey, this really sucks. I have all of these things stacked against me right now, and it's manifesting in this tendinitis. It's probably not as bad as the pain is making it seem because I have all of these other factors on board that I know are sensitizing it.
Yeah.
Right? It lasted for about 7 months, and then all of a sudden it disappeared. Great.
Yeah.
I have literally no problem with my thumb now, and I didn't do anything to treat it other than start getting back on track with my sleep.
Yeah. Amazing.
So it's fine. You know what I mean? And I think that sometimes taking those broader perspectives gives us permission too to just be like, hey, this is how bodies work, right? I talk about that with my spouse. We're like, oh, my back hurts today. And it's like, maybe it's because we've been kind of eating stuff that doesn't make us feel good for a week because we've just been tired and getting takeout. Like, oh, cool. Let's see how we feel in a week after we eat some salads.
Yeah. Yeah.
And that's okay.
But it's so true,
right?
though.
You
It's
don't
like
have to do. You don't have to do your extensions or whatever. You can
You're
just be like, I'm going to try eating salad.
I'm
for a week.
sluggish and I'm exhausted
better.
and I feel bloated and I feel great. Well, let's see. You had McDonald's 3 times this week and you had pizza last night and maybe.
Yeah. Right. And so if it's in your control, if you are a person for whom controlling what you eat is an option, right? I mean, that's always my preface for these things. But if you're in a situation where you can say, hey, this week I'm going to eat X, Y, or Z, then that's an option for you.
Yeah.
And see how you feel.
So what do you say to the patient who doesn't have that option about food choices?
Yeah, that's super hard.
That's a hard one.
Super hard. Sometimes I like to talk to them and I always put the ball in someone else's court, right? But we might say, like, what's a typical day look like for you in terms of food, right? Because I don't want to start by saying you need to eat X, Y, or Z. I don't think there are bad foods. I don't think there are good foods. I think there is food. The most important thing is that people have. And so then depending on where that person is with their situation, maybe there is not an option right now for that person to be changing their diet.
Yeah.
Fine. Then we're going to look at what else is in their cup. Maybe there are other things they could do that might make them feel better and tip the scale for them. Maybe there are other things they could change to take out of like the I don't feel so good side of their scale. So maybe we don't even address it. Or maybe we do. And we take the approach of let's not over wellness industry your diet. Let's make sure we know that canned vegetables, frozen vegetables, ugly vegetables are like just as fine.
Yeah, they're still vegetables.
Yeah, exactly. Frozen produce is an amazing resource for people.
Yeah.
And there are a lot of vegetables in a lot of foods that we don't think about, like dipping your chip in salsa, And so it might just be changing one little thing at a time. There's a great, what is her name? Her last name is Minnie Spence. She's on Instagram as the Nutrition Tea and just wrote a book called Live Nourished. Great book. She is a dietitian and works in the public health system in New York City and is just an awesome resource for just advocating for people. Yeah, she's great. She advocates for people to... Yes, Shanna. I couldn't remember her first name.
Live nourished, make peace with food, banish body shame, and reclaim joy. I will link to that in the show notes.
So she's great. Yeah, because she also kind of works from a health at every size perspective too.
Nice. Which
is something I think physical therapists really need to embrace a bit.
Well, and I think you bring up a good point, and I just wanted to expand on a little bit of like, again, I think in general, PTs come to a situation with good intent, but sometimes not always tact. That someone who is not in a situation where changing their diet significantly just isn't realistic, it's easy to take a kind of a shame approach of just like, well, you need to do this. This is the way, or, why can't you just make this one change when you don't know their story and there's a whole bunch of reasons. So I think it's important to take that. Okay, we'll take this off the table. This isn't something we can do right now. So let's move somewhere else. And just to take that, it's truly a teammate. That's not the right approach.
It's like a strengths-based approach in my opinion.
Yeah.
It's like, let's see what you have in your power. What are your strengths, right?
Yeah.
I know if I go see a physical therapist, which I have done, and you give me more than one exercise to do, it's not going to do it.
Yeah.
Right?
Yeah.
I've been there.
Yeah.
I'm going to do one.
Yeah.
And
if I don't like the exercise, I might not even do that one.
I'm probably not going to do it.
Yeah.
So you need to give me one exercise, right? But if you tell me that you want me to do whatever breathing exercise every hour, I can probably handle that a lot more than I can handle the others. And so everybody's going to be different. And it just goes back again to us doing an assessment of the human in front of you.
Yeah.
Right? And it doesn't matter if they are a little kid, if they are a grown up. You have to find out things like, how do you get around? If you're a kid, Abby Gordon has amazing questions that she asks her kids. Like, I don't remember the exact words, but right, like, how do you get to school? Who takes you to your soccer match? What are your favorite fruits and vegetables? Right? And we also have to remember, especially with grown-ups, but more and more with kids, I think because of a lot of weight shaming that's happening in the world, there are inherent biases and narratives that people have. So if you ask someone about their food, most people are already going to be on the defense.
Yeah.
I also think when we talk about food, and I'm just going on a little bit of a tangent, but especially in our female population, especially like middle-aged women, calorie intake in general is a huge problem. I don't know a single middle-aged woman that I've worked with who didn't at one point comment on their body and think they need to lose weight or eat less. And if I actually broke down how much they're eating a day, they're probably not eating enough.
Yeah.
And so that's a factor as well. I worked with older adults. Calories.
And hydration, I would imagine.
Huge.
Yeah.
Hydration is huge. I mean, 50% of the people I see in a hospital floor any day are there for a UTI.
And you ask them, why don't you drink more water? Well, I don't want to have to get up and go to the bathroom in the middle of the night.
Pee. Yeah.
Totally. I get it. Funny, I was just about to say, and you beat me to it because we were very pro soapbox here. So if you have soapboxes, climb on. I mean, you've already been kind of doing it, but I just want to say, if you got more, I'm not going to stop you. I have a question for you then.
Oh, go for it.
Okay. This is coming direct from my students.
Ooh, okay.
Yeah. So, and I was this student as well. So I'm going to preface what I'm about to say with that. I was this student. I get a lot of feedback on my classes. One of the biggest classes that I teach is neurologic interventions. Okay. So in the class, we have a lot of time in our labs for students to try to come up with interventions for this simulated case, blah, blah, blah. And without fail, we get feedback every year saying, I want more structure. I want more, tell me what to do. And and it's tough. Like, yes, I want to give them some foundational steps to take, some foundational concepts, things like that. But I don't want, because of the nature of clinical care, and especially in neurologic clinical care, like I don't want to give you a recipe because there is no recipe, So how do you, because if you have the answer, I'm going to write it down and I'm going to use it. How do you get students and new clinicians to recognize maybe their own creative abilities, or how to tap into those creative abilities, or that it's okay to try something then find out it doesn't work? And, like, how do you do that?
Oh, it's so hard because I was sort of that student, but sort of not that student. It sort of depended on the setting I was in.
Yep.
I think I feel strongly, and I am not the provider that thinks you need to be able to do everything that you teach or have your patients do. You can teach someone a heavy back squat if you don't squat with a barbell. Like, that is all fine. That being said, your own person and your own lived experience can very much inform what you do, right? I have no idea what to do with an 11-month-old with a fever, but I know what I do for myself, and I'm going to apply that a little bit.
Yeah.
And so I do think, I mean, at least if it probably applies to neuro, it applies to ortho, that taking a critical look at what your own responses to things are and evaluating those for better or for worse, I think can impact how you intervene with people too, right? So it's like, okay, what do I do when I feel this way? Maybe I do X, Y, or Z exercise. So I do think that one, it's like, there's nothing wrong with pulling from your own lived experiences. You need to blend those with the things that you've now learned so that you're not just treating only based on personal experience. But I like to have people pull a lot from what they do and experiment with themselves too. Like, go spend some time and play. See what it feels like to, I mean, if you go back to neuro, see what it feels like to get on the mat on all fours and have someone knock your elbows out from under you and see what it feels like to try to find it, right? Like, go play and spend some time experimenting and make stuff up.
Yeah.
And then I think in terms of being able to make mistakes, I have a soapbox.
You have time.
But I think that the educational system, all the way from grade school up until people are entering doctorate level programs where you're trying to teach creativity, are limiting creativity. And I think that we have a big problem with that, that we are now in a situation where we are teaching for tests, and there is a huge fear of getting things wrong because we are being taught in a right or wrong setting.
Every PT student has, at the end of their academic journey, a very long multiple choice test to face.
You either pass or fail.
You either pass or you fail.
Yeah, and I think that it really starts in grade school and high school at this point now too, and that's really hard. And so creating environments for debate, analytical writing, I think, is a critical skill for people.
Yeah.
I have a bit of a bias there because I come from liberal arts, humanities, and performing arts, and not from a science background. So I had the privilege of learning history through debate and primary source documents. Right. But I really feel like that is a skill that if students were being taught that all the way through high school, there may be less fear of being wrong.
Yeah. Less fear of let's try it and see what happens.
Right. Like we need students to know that everything is a gray area, especially medicine.
Yeah, yeah. And I try to instill in my students, I know a lot of my colleagues do as well, is that, I don't want to make clones of myself. I don't want the student to give me the answer they think I want to hear. I want you to give me an answer that you are confident in and you can justify to me. Why are you doing what you're doing? And if it's
exactly,
and if your justification is a little bit off, we can talk about it and be like, well, okay, I can see where you're coming from it, but you're probably going to see this result versus this result. So what might you change? And so it's that conversation. And, if you can set up that environment, and I think with our patients as well, it's like, well, what exercise do you think we want to try? Like, what do you think might help? Okay, we can give it a shot, see if it's great. If it's not, well, we can adjust it. Like, that's okay. That's great.
Yeah, I think being upfront with our patients that, like, medicine is gray, and half of this is informed trial and error, and we're going to work together to see what's working, I think is totally appropriate. Yeah. And like, I was just orienting a new PTA at our hospital who's a new grad and new to our hospital, and it's like, how do you, decide what to do? And I'm like, some of it's just reps under your belt.
Yeah.
Some of it's just
there is no substitute for experience.
Of people, and that's okay. And just saying, we have to play. But I also think one of the things for me when I was a student, especially on clinical rotations, when I felt like, oh my gosh, I'm never going to be as amazing as this Aon fellow I'm following, right? Was hearing like their own stories of botched care.
Oh, yeah. Yeah.
Right? Like, oh yeah, the other day I said X to this person and they got PO'd and I had to backpedal. Right? Like, I remember Sarah Haig is one of my like role models in life, right? She's incredible. And I remember the first time she was talking about, she's like, oh yeah, sometimes you just definitely say the wrong thing. And I was like, oh my gosh, oh, I feel so much better, right? Knowing that you too sometimes have to backpedal.
Yeah.
And it's like we are human and make mistakes. There are times when I have gone on a complete soapbox rant to someone about all of the healthy behaviors they could do and totally missed some social determinants of health. Okay, I've been a PT for 10 years. All right.
Yep.
That's still kind of new.
Still learning
it's
here.
Fine. Sometimes you make a mistake, and
Yeah.
then the best thing you can do is apologize,
Yep.
So, yeah,
Oh, funny.
sort of a winding answer to your
No, it's
question.
great. I love it. I love it. Sarah, thank you for your time and sharing
for
your.
having me.
Oh, absolutely, of course. If you want to be found, do you want to be found?
Sure.
Where can people find you?
I'd say I'm less active on social media now than in the past.
Mm-hmm.
That may shift a little bit in the future. So you can find me on X, Twitter, or Blue Sky, or Instagram. I'm like at Sarah Cruser or at Sarah_Cruser. And I'm always open to a personal email. I am just sarah@sarahcruser.com.
There we
So
go.
I'm always happy to chat or troubleshoot any kind of like clinical situation with
Nice.
people.
I will have links to all those things in the show notes. So,
Awesome.
Sarah, keep being awesome.
Thank you for having me. This has been super fun.
All right. Dr. Sarah Cruser is a woman of many talents, a thinker of big thoughts and a doer of good deeds. If you'd like to know more about her work, you can find her at Sarah Cruser on social media. Cruser is spelled Cruser, or on her website, sarahcruser.com. Waves is a production of APTA Michigan. It is hosted by me, Andy Wicks, and with production help from Joey Lapidi. We can be found online at www.aptami.org or on social media at APTAMI If you are a PT or PTA in Michigan, don't forget that you can earn PDR credits simply by listening to Waves episodes. As always, thank you for listening, and may your documentation always be done on time.